it's great to see how much more information is now available for patients. It's really great. So again, I'm Gabe Manis, and I have the privilege of kicking this session off and was assigned the topic of essential information for newly diagnosed patients. The agenda, I thought I would keep it very simple, and I apologize if it's maybe a little too basic for some of the people in the audience, but what I thought I would do is to cover some of the most common questions I get from patients who come to me with a new diagnosis of AML. So first and foremost, the most basic question really, what is AML? How did I get this? Is it curable? How is it treated? What can I do to help fight this? And what other questions should I be asking? So to start, what is AML? I thought I would break it down by each of the letters. So the A, of course, stands for acute. This means that symptoms usually come on quickly. Often, patients are feeling totally fine up until 2-3 months before they're diagnosed. And then progressively over that time, they start to feel more tired, more short of breath, develop other symptoms, as we'll talk about. And the treatment is often initiated urgently, sometimes within days, often within a few weeks at most. Myeloid refers to the subtype of blood cell, and here is just a basic cartoon of how blood cells are made. All blood is made in the bone marrow, and it starts with a blood stem cell that can divide into any kind of blood cell. And there are really two pathways. There's a lymphoid pathway and a myeloid pathway. On the lymphoid side, these cells end up developing into lymphocytes. And when people have lymphoma, which is a different kind of blood cancer, that's a cancer on the lymphoid side. AML is a cancer on the myeloid side. And as you can see from this diagram, myeloid stem cells not only divide into white blood cells like this neutrophil pictured here, but they also go on to make the red blood cells and the platelets. And leukemia is a cancer of these blood cells, often at this sort of premature myeloblast stage. And so we often define acute leukemia by more than 20% blasts, which is another name for leukemia cells, in the blood, or more commonly in the bone marrow. So there are three main types of blood cells. There are the white blood cells, which really are your immune cells. These cells help fight off infections, and we spend a lot of time talking about neutrophils, which are a subset of the white blood cells, and these are the cells that are really most important for fighting off life-threatening bacterial and fungal infections. The red blood cells carry oxygen, and platelets help form clots and prevent bleeding. So on the right side, I have a sort of cartoon picture of a bone, and inside a normal bone marrow, the cells are nice and spread out. There's plenty of free space and fat and things there. There are typically less than 5% detectable leukemia cells or blasts, and the number of red cells, white cells, and platelets that we measure in the blood are normal. In leukemia, this cancerous cell starts to grow out of control, essentially crowding out the normal blood cells that are being made in the bone marrow. And so, leukemia is again defined by more than 20% blasts in the bone marrow, typically decreased red blood cells and platelets, and white blood cells may be either high or low, but in either case, they tend not to work well to fight off infection. So what are the results of this? So when the white blood cells are low or aren't working well, patients often can develop fevers, they can get infections, often pneumonias, bloodstream infections, urinary tract infections. When red blood cells are low, this is what is commonly referred to as anemia, and the manifestation of that is typically people feel tired, they may have trouble breathing, especially when climbing flights of stairs or walking up a hill or sort of rushing to catch a train or something. When the platelets are low, people may often get easy bruising or bleeding. And so these are really some of the principal manifestations of the malfunction that happens at the level of the bone marrow. Very common question I get is, how did I get this? So these percentages are sort of relatively approximate here, but the majority of AML we think is just bad luck. It tends to be a disease of older people. The average age is around 70 years old when people are diagnosed with AML, although people can be diagnosed at all ages. But over time, as we get older, mistakes are being made as our cells are going through the normal cell division process. And if just the right mistakes are made and just the right genes, that can go on to trigger AML. We do think maybe a quarter to a third of patients develop AML as a result of the environment. There are obviously a lot of things that we can't measure that may be contributing, but there are a couple things that we do know for sure can increase the likelihood of getting AML. And that includes having received prior chemotherapy or radiation for another type of cancer, so for breast cancer, colon cancer, et cetera. And then patients who have a pre-existing bone marrow problem. So whether it's a chronic leukemia, whether it's a condition called myelodysplastic syndrome, which was previously referred to as sort of a pre-leukemia, any of those bone marrow problems can then go on to become acute myeloid leukemia. Lastly, I think a lot of people are often worried about whether they can pass this down to their children. We used to say that this wasn't something that could be passed down in families, and probably more than 90% are not, but we know that there is a small fraction that we do think is inherited, and there are certain gene mutations and chromosome changes that may suggest that. I think the next and maybe most important things on patients' minds is this curable? And so, I start out with this graph here, and on the y-axis, you can see I have the amount of leukemia in a person's body, and on the x-axis, we have time. And at diagnosis, there's a lot of leukemia in the body as pictured here. The first treatment is often referred to as induction, and really that's a term that means that we try to induce remission. And what does remission mean? Well, remission is sort of an imaginary line, and remission means that we can't detect the leukemia. The blood counts return to normal, and when we look in the bone marrow, we see less than 5% blasts. But as you can see, there's still leukemia left there hiding under the surface. So the next step in treatment is often referred to as consolidation. We try and decrease further the amount of leukemia in the bone marrow, and sometimes we may refer to maintenance treatments, which may not decrease the amount, but sort of keeps things at bay. But then for some patients, there is the possibility of cure, meaning that the leukemia is completely gone and that it never comes back. And so for many patients, the goal is, well, for all patients, I would say the goal is to get the leukemia first into remission, and then to discuss with your treating physician, is cure a possibility? And we don't have a test that can tell someone, are they cured? And so, we really, the aim is to get patients into remission and do everything we can to try and keep the leukemia in remission as long as possible, and potentially even cure it. Now, what goes into curability? So patients that are older are less likely to be cured. And there are certain genetic changes in the leukemia cells themselves that makes the leukemia more difficult to be cured. And so for many patients, unfortunately, AML is not a curable cancer. And if it's not curable, the goal is typically to get it into remission and to live as well as possible for as long as possible, but without the prospect that the leukemia will stay in remission forever. The treatment really depends on exactly those things, older age and certain genetics of the leukemia. And so for the older, less fit patient, or the patient who has certain gene and chromosome changes in their leukemia cells that are less likely to respond to sort of the heavy-duty treatment that we use for younger people, there are lower intensity treatments that may have fewer potential side effects. These treatments are definitely given in the clinic, not in the hospital, so in the outpatient setting. And these are treatments that are given, unfortunately, indefinitely until the leukemia comes back. And so, most often these treatments are given for several days out of every month and are repeated month after month. Now, there may be older patients or patients with sort of poor risk gene changes who get started on this lower intensity treatment, but may ultimately be candidates for bone marrow or stem cell transplant with the hope of potentially curing the leukemia. For the younger, healthier patients or those with certain gene changes, we historically have given much more intensive treatment. These treatments can have a lot of side effects. They generally require at least a month in the hospital. And these treatments are typically time limited. These are not given indefinitely. So patients may get 1, 2, 3, 4 cycles. And then for most of these patients, we would recommend undergoing a bone marrow transplant for the best chance of being cured. Although there are some patients who may be cured without a bone marrow transplant. So what to expect during treatment? This is, a little bit difficult because treatments can vary quite dramatically, but blood cells, which often start low, can get even lower. So low red blood cells, low platelets, low white blood cells. Unfortunately, nausea, diarrhea, constipation are somewhat common across all of the treatments that we use. Fatigue, similarly, very common. Hair loss, uncommon with the lower intensity treatments, but is common with the higher intensity treatments. I think it's very common for most AML patients, especially early on in the diagnosis, to go through various degrees of anxiety or depression. For younger patients, getting the higher intensity treatments, often fertility is an issue. And of course, there are frequent blood draws and frequent bone marrow biopsies. And so because of the low red blood cells and platelets, frequently, especially early on in treatment, patients require blood and platelet transfusions. We can't transfuse white blood cells. So when the white blood cells are low, we often prescribe preventative antibacterial, antiviral, and antifungal medications to help prevent infections. For the symptoms that come along with AML and its treatment, we have a lot of good supportive medications these days to prevent things like nausea, diarrhea. We often engage our palliative care or symptom management experts early on in the course of treatment to help manage some of the side effects. And for these frequent blood draws, it's very common for us to recommend placement of a special IV that can stay in for a longer term basis, which makes it easier to draw blood and to give blood transfusions and also chemotherapy infusions. So what can you do to help maximize your chance of success during treatment? First, I always tell people to stay active. That doesn't mean you need to go out and run a marathon or sort of push yourself to the brink of exhaustion, but it is important to, stay active. I think it's common for people with AML, especially when they're getting treatment, to feel more tired, not have a lot of motivation to get up and do something. But it's sort of a vicious cycle. The more you sit around, lay in bed, the less energy you have. And so, even if it's just going out for a quick walk, that helps you get through the treatment. Second thing is to eat. I get a lot of questions about what are the exact things I should eat and what things I shouldn't eat. And, I think really the most important thing is just to maintain, enough calories day to day, between the AML itself and between some of the side effects from drugs that may cause nausea or taste changes. I think it can often be hard just to, maintain just sort of a basic level of calories per day. And so, whatever it is that you enjoy eating, just try and keep doing that throughout the course of treatment. And then last but not least, this is a difficult diagnosis, and the treatment is hard, and it is, absolutely life-changing. And so part of it is coming to terms with having this disease and being able to sort of focus on the end goal, whatever it is, whether it's getting into remission and staying in remission as long as possible, whether it's getting to a transplant, getting to a cure. And people can do this in a variety of ways, whether it's on their own, whether it's talking to a therapist, whether it's being on medication. But I think the mental aspect of going through this journey is just as important as any of the other things. Last slide here, what other things should I ask? A common question I get is, what stage of AML do I have? Most solid tumor cancers like breast cancer, lung cancer, colon cancer are staged based on how far they have spread. Because leukemia is a cancer of the blood and the blood is all throughout the body, there's no stage of AML, either you have it or you don't. There are specific sort of categories of risk level, and I think some of my colleagues may talk about that in a little bit more detail. And those are what really informs prognosis. So these risk categories that we talk about that are largely based on the gene and chromosome changes within the leukemia cells themselves, but also, as I mentioned before, having a lot to do with age. Is cure possible? I think that's an important question to learn up front. What is the standard treatment? What side effects should I expect? I think it's helpful to think, if the initial treatment doesn't work up front, or if at some point the leukemia comes back, what are the other options that may be out there down the road? To that end, I think with any serious cancer, it's always important to at least think about whether you want to get a second opinion. And AML is a relatively rare type of cancer, and so if you're being treated at a place where maybe they don't see a lot of acute leukemia, I think it may be helpful to ask your doctor if it's possible to get a second opinion. And I would say most, if not all, doctors have no problem with sending their patients to get an expert on board to help out with the treatment planning. And then, finally, are there any clinical trials available? There's been a lot of really exciting progress made in the AML world over the last 5 or 6 years, a lot of exciting new drugs and drug combinations. And so I think asking about clinical trials is also a really important question.